Hi everyone, my name's Kushi,
I'm Camila.
And I'm Tanya.
and we're going to be presenting on the different drug effects on the frog neuromuscular junction. We studied drug effect on the neuromuscular junction. We performed extracellular recordings on the alpha A motor neurons of the frog sciatic nerve, the skeletal muscle fibers of the frog gastrocnemius muscle, and the neuromuscular junction that connects both of them to determine some electrical properties in response to three different drugs. These recordings were done to study recruitment and synaptic delay. So our first drug is verapamil. Verapamil is an L-type calcium channel blocker drug, and some of its clinical uses includes helping to lower high blood pressure and also widening blood vessels to control and prevent chest pain.
The next drug we studied was succinylcholine, which is a short-term depolarizing neuromuscular blocking agent, which causes temporary skeletal muscle paralysis. It's used in the clinical setting to relax muscles during surgery or to relax muscles while using a breathing machine.
And the last drug we studied was curare, which mimics acetylcholine and acts as a competitive postsynaptic antagonist, which essentially binds to the acetylcholine receptors. It can be used as a paralyzing agent during medical operations to prevent unnecessary muscle contractions. And then at high doses, it can be toxic and cause paralysis of skeletal muscle.
So as for results, a threshold recruitment study was performed by using different stimulus amplitudes and measuring the resulting compound action potential. A compound action potential, aka a CAP, is the summation of the action potentials from multiple fibers within a nerve. A control is performed before the addition of any drug. The threshold is what stimulus generated the first cap. The threshold for the control and after the addition of verapamil was between the stimulus amplitudes of 85 millivolts and 90 millivolts. A slight increase in the cap amplitude, as seen in the graph, was seen after the addition of verapamil. The muscle action potential was also measured from the same experiment. The muscle action potential is the accumulation of multiple action potentials generating from multiple muscle fibers in the frog gastrocnemius muscle. The MAP thresholds for the control and after verapamil is added are both between 85 millivolts and 90 millivolts. From the data seen and the figure, there is a slight decrease in the maximum MAP amplitude for the trial when verapamil was added compared to the control. Lastly, this table displays the conduction velocity, map latency, and synaptic delay for both the control and when the drug was added onto the gastrocnemius muscle of the frog. The conduction velocity, map latencies, and synaptic delay remains roughly the same between the control and drug applications. However, the conduction velocity of the control is slightly faster than the trial for verapamil. It can be concluded that verapamil does not have a direct effect on these three variables since there's no significant change.
And then moving on to succinylcholine, the figure on the left displays the threshold potential of the cap when no drug was added, also known as the control, and when succinylcholine was poured onto the gastrocnemius muscle of the frog. The control was made to serve as a point of comparison, and then as seen in the figure, both caps reached their threshold after a stimulus amplitude of around 75 to 80 millivolts. And then again here, the figure on the left displays the map amplitudes following no addition of the drug, and then when the succinylcholine was added onto the gastrocnemius muscle. According to the figure, the threshold for the map recruitment was between 75 and 80 millivolts for both the control and the drug. However, there is a significant decrease in the map amplitude following the addition of the succinylcholine onto the muscle. For the control, the max amplitude for the map was 2.33 millivolts and was reached after a 135 millivolt stimulus amplitude. On the other hand, the max amplitude for the map with succinylcholine present was 1.15 millivolts after a stimulus amplitude of 115 millivolts, which is a significant decrease compared to the control. And then this table displays the conduction velocity, map latency, and synaptic delay of both the control and when the drug was added onto the muscle of the frog. The conduction velocity, map latencies, and synaptic delay remain roughly the same between the control and drug applications. Because of this, it can be concluded that succinylcholine does not have a direct effect on these three variables, since the change is not significant and can be due to experimental factors rather than the drug itself.
Panel A on the left shows the cap amplitude for both curare and control, and then panel B shows the map amplitude. Both control and curare treatment groups reached a cap threshold at 90 millivolts, and then a max map was reached at 110 millivolts across both conditions. For the control, a max map was at an amplitude of 7.88, millivolts, which while Karawi had a max map at an amplitude of 3.9 millivolts, which was significantly lower than the control group. And then the conduction velocity, map latency, and synaptic delay had the same calculation, and no differences were found across conditions.
Now to just summarize the anatomy of the neuromuscular junction, there's a presynaptic terminal, a synaptic cleft, and a postsynaptic membrane. The presynaptic terminal of the motor neuron contains the acetylcholine synaptic vesicles and the calcium PQ type channels. The synaptic cleft is the space between a neuron and a muscle fiber. And then lastly, the postsynaptic membrane is the end plate of the muscle fiber and contains the nicotinic cholinergic receptors.
So moving on to the neuromuscular junction function, the alpha A motor neurons generates an action potential which reaches the presynaptic terminal and causes an influx of calcium from the PQ type calcium channels. This influx of calcium causes the fusion of vesicles to the presynaptic membrane and the release of acetylcholine. The acetylcholine will then diffuse across the synaptic cleft and bind to the nicotinic cholinergic receptors of the muscle end plate, which causes an increase in the permeability of muscle membrane to cations. Thus, sodium enters the muscle fibers. This causes a depolarization of the end plate, and if this end plate potential reaches the threshold potential, then an action potential will be generated. This experiment is recording the summation of multiple of these action potentials happening from many muscle fibers in the frog gastrocnemius muscle. So verapamil is a drug that blocks the channel, which comes later on and plays a role in generating the actual contraction. The map will spread across the sarcolemma and reach the T-tubules. When the action potential reaches the T-tubules, this causes the L-type calcium channels to open. However, verapamil blocks these L-type calcium channels, so no calcium influx will occur. If there's no influx of calcium, then the rhyatidine receptors in the sarcoplasmic reticulum will not open and release calcium. Thus, no increase of calcium in the cytosol will occur, so less calcium means that there's less of a chance for calcium to bind to troponin, causing tropomyosin to move away from the myosin binding sites on actin, initiating the actual muscle contraction. Thus, verapamil should cause the muscle contraction to decrease, but in our experiment, we're measuring the action potential, not the contraction. So theoretically, the muscle action potential amplitude should remain the same despite the addition of verapamil. Our data shows a slight increase in the cap amplitude upon the addition of verapamil. Since verapamil was added onto the frog gastrocnemius muscle and not the frog sciatic nerve, no changes in the amplitude should be observed for the cap. The slight increase in cap could be just due to the frog sciatic nerve having better contact with the recording electrodes for the trial when verapamil was added. However, our data shows that verapamil is lowering the amplitude of the map. Previous research has shown that verapamil has the potential to bind to PQ-type channels, which explains the decrease in amplitude. If verapamil binds to these PQ channels, then this causes there to be less acetylcholine release. Less acetylcholine release means that not all the muscle fibers will be able to reach threshold and initiate an action potential. This causes there to be a decrease in the map amplitude. So the second quantitative measure we're looking at is the synaptic delay. In short, synaptic delay is the delay between the presynaptic depolarization and the postsynaptic depolarization. As said in the last slide, verapamil is targeting the L-type calcium channels, not the PQ type. Verapamil was not added to the sciatic nerve, so no difference in conduction velocity of the cap should be seen between the control and experimental. Thus, the alpha A motor neuron was still able to depolarize the presynaptic terminal and trigger the opening of the PQ calcium channels. Thus, a normal amount of acetylcholine is still able to diffuse across the synaptic cleft and bind to the nicotinic cholinergic receptors at the muscle end plate. In our case, the synaptic delay also constitutes the muscle action potential reaching the muscle recording electrode. Thus, verapamil should not have an effect on the time for the synaptic delay because it was blocking the L-type calcium channels that are important for actually generating the contraction, not the action potential, which is what we are recording. A slight increase in the conduction velocity for the control cap was seen, which can be due to the experimental factors and differences when recording as opposed to the drug having an effect. From our data, there's a decrease in the map amplitude as seen in the previous slide. This means that not all the muscle fibers are reaching their threshold and firing an action potential, so we should see a decrease in acetylcholine release. This causes an increase in synaptic delay. However, from our data, we did not see this. A possible explanation would be that verapamil is not getting to all the neuromuscular junctions in the actual frog gastrocnemius muscle, so some are firing like normal, which causes synaptic delay to not change as much.
In terms of succinylcholine, when the drug is added to the muscle, it binds to the nicotinic ACH receptors on the postsynaptic membrane of the NMJ and mimics acetylcholine. This causes an increase in the opening of ion channels and a depolarization effect. In a control setting, when ACH binds to the nicotinic receptors, it quickly gets broken down by acetylcholinesterase, also known as ACHE. However, ACHE does not break down succinylcholine, so it stays in the synaptic cleft the whole time, bound to the nicotinic receptors. As a result, there's a persistent depolarization, which causes the voltage-gated sodium channels to remain in a constant inactivated state. This prevents repolarization from occurring, and no new action potential can occur because these voltage-gated channels respond to a certain voltage in order to activate. Thus, further nerve impulse transmission becomes prevented when succinylcholine is present, causing a temporary muscle paralysis and a decrease in overall MAP amplitude. And then this does not directly affect cap amplitudes because succinylcholine acts on the postsynaptic membrane and caps occur in the presynaptic terminal. Caps are not directly impacted as a result of this drug being added. And then succinylcholine can either increase, decrease, or have no effect on synaptic delay. One possibility is that because there's thousands of NMJs in the frog muscles, succinylcholine can come onto the nicotinic NMJ and bind to only some of the ACH receptors. This will then cause the threshold to become slightly lower due to the persistent depolarization that the drug causes. This makes it easier for ACH to come in and reach the threshold when bound to the other nicotinic receptors on the postsynaptic cell, generating EPP sooner, causing a decrease in synaptic delay. And then as a result, the MAP would reach threshold quicker with succinylcholine. And then another possibility, which is more likely, is that when succinylcholine is added to the NNJ and mimics ACH, it can bind to all the nicotinic ACH receptors on the postsynaptic membrane. And then as a result, the persistent depolarization caused by the drug will stay active for longer, causing more sodium to stay in an activated state, due to the constant depolarization. This will then prevent the muscle from repolarizing, meaning the muscle stays contracted for a longer period of time. And then as a result, this makes it harder for the EPP's threshold to get reached and MAP to occur, thus increasing synaptic delay significantly. And then a last possibility is that the addition of succinylcholine can cause no change to the synaptic delay. And then this would be due to the succinylcholine not reaching any of the nicotinic ACH receptors on the postsynaptic membrane, indicating that the NMJs are all able to be remaining working properly. And then in our data, because there was no difference in the synaptic delay when the drug was added, it could be due to a variety of factors. First, since the succinylcholine is being added onto the muscle directly, there's a possibility that it did not soak into the middle of the muscle. The muscle is super big, meaning the drug has to travel to get to the middle of it where the NMJs are located. And then if succinylcholine did not reach the middle of the muscle, this means the NMJ is working normally and was not affected. If this were the case, it would explain why there was no notable difference in the synaptic delay between the control and when the drug was added.
Compound action potentials happen before the NMJ, so Curare does not affect them or ACH release. At the synapse of the NMJ, ACH usually binds to nicotinic ACH receptors, which opens sodium channels and creates an EPP and triggers the muscle action potential. Curare competes with ACH by binding to these receptors without activating them, reducing the number of active channels and indirectly decreasing sodium influx. This decreases the EPP size and prevents MAP initiation. Since the EPP is lower and may fail to reach thresholds, not all of the muscle fibers are recruited to elicit a muscle action potential. At low to medium doses, Curare blocks some receptors, but not all, so some muscle fibers still function normally, which explains the reduced but still present MAP amplitude. At higher doses, the EPP fails to reach thresholds and muscle fibers do not generate action potentials. In summary, Curare acts postsynaptically to reduce MAP amplitude by blocking the nicotinic receptors, but it does not affect cap amplitude since caps happen presynaptically. And then ideally, the more activated ACH receptors you have, the faster and easier it is for EPP to reach the thresholds. Curare acts as a competitive blocker by mimicking ACH and binding to nicotinic ACH receptors without activating them. This prevents ACH from fully binding and activating the receptors, which again indirectly reduces sodium influx and decreases the strength of the EPP. With less activated receptors, it takes longer for the EPP to reach thresholds, which slows down postsynaptic depolarization and delays the MAP. However, in our data, there was no significant change in synaptic delay between controlled and Curare groups. This is likely because Curare was applied at a low to medium dose on a thick muscle, so not all of the muscle fibers were affected. Some of the NMJs likely remained functional and continued to respond normally. Some synaptic delays based on the fast the fastest conducting fibers. If those weren't blocked by Kurari, the timing of map initiation would remain the same. So even though Kurari slowed or weakened EPPs in some fibers, the unaffected ones still fired normally, which explains why the overall synaptic delay stayed consistent in both groups.
Thank you.
Thank you.